I'm Sammy Saab. I'm a liver doctor at UCLA. And I got to tell you, it's a great pleasure to be among so many friends today. People I haven't seen in years. So today we're talking about eliminating hepatitis C. And we're going to go from diagnosis to cure. In the next 20 minutes, we're going to cover three very important objectives. We're going to briefly discuss, define the natural history of hepatitis C, and focus how the epidemiology of hepatitis C has evolved significantly. The patient we saw 10 years ago looks nothing like the patient we see today with hepatitis C, nothing. We're going to talk about understanding the barriers for treatment and cure. We have a paper we published last year in hepatology, and it was a great paper. We talked about how we could cure hepatitis C, how we could eliminate it, and then we have a new epidemic right now under our midst. And lastly, talk about what is the impact of antiviral therapy on disease progression and eventual elimination. So using this slide a million times, and it basically reminds us that hepatitis C is a very important health issue. It's a major cause of cirrhosis, major reason for liver transplantation, and one of the most common indications for liver transplantation. But we can't forget that hepatitis C is a systemic disease. Not only does it cause cirrhosis and liver failure, but it also causes other things like glomerulonephritis, lymphoma, glucose intolerance, Sicca syndrome, perfused cutaneous tartar, and the list goes on and on. Hepatitis C is a systemic disease. One of the interesting findings that we're learning is that the rate of spontaneous clearance may be much higher than 15 to 25%. There are many people looking at large medical record systems from Kaiser, University of Michigan, even at UCLA, and we think the spontaneous clearance could be as high as 25 to 40%. Probably because of different demographic picture we're looking at today than we looked at before. Hepatitis C has gone through major changes in our lifetime. And we take it for granted that people like Gary Gidnick, over several decades ago, was one of the first to describe the antibody that's now used routinely to screen for hepatitis C. And we have therapies that can eliminate hepatitis C with now major side effects and easy tolerable. The biggest barrier curing someone, it's not the cost of medication, because the cost of drugs have come down substantially. And the cost of drugs today are less than 20% what we paid for 5 years ago. The biggest barrier to curing hepatitis C and eliminating this infection is knowing who's infected. We've also learned that one of the biggest cohorts of people with hepatitis C are baby boomers. And if you look at 100 people with hepatitis C, over 80% of people born between 1945 and 1965, they're baby boomers. And we think the reason why is not just drug use, but blood transfusions. We think the major reason why so many boomers with hepatitis C was from blood transfusions, iatrogenically infected. So the biggest barrier is knowing who's infected. And so a number of years ago at UCLA, we started screening people at all boomers with hepatitis C at UCLA. And it was part of the EMR system. So when a patient saw their doctor, a light bulb would flash. Bing! Your patient, the baby boomer, is screened for hepatitis C. And you have the option of opting out. And what we found is by this simple bell, that our screening rates went up tremendously. And so was the ability to identify people with hepatitis C infection. And we thought we were doing a great job, identifying people who had hepatitis C. The problem is that there is a big gap between diagnosis and linkage to care. Some people come back for their viral loads and then lost to follow-up. Some people got their viral load tested, never came back to treatment. the independent predictors of these barriers to linkage of care, one was age. The younger someone is, the less likely they were to be involved in the healthcare system and follow up with testing and treatment. And the other predictor was patients who had a recent history of drug use. So we wrote this paper last year in hepatology, and it got great reviews. And then we're confronted with a new epidemic. So this previous cohort of baby boomers, where most were infected blood transfusions, and where most of these baby boomers are men, not women, but men, the vast majority, and where we have established guidelines for screening. And these individuals are engaged in the healthcare system, right? They're getting their colonoscopies, they're getting the flu vaccines, they're getting a cholesterol check, they're engaged in the healthcare system. Right now, we're in the midst of a new wave of hepatitis C. Young adults. I was speaking to Dr. Austin. Where's Dr. Austin? Are you still awake, Dr. Austin? All right. We're talking about our experience with hepatitis C, and we're talking about right now most of our patients with hepatitis C are no longer baby boomers. They're people in the 20, 30 years of age. They're kids. They're experimenting with drugs. And what we're seeing is equal representation of men and women. Men and women are equally represented. We see another phenomenon of liver disease. That's alcoholism. Similar problem. We're having similar rates of liver failure in men and women. The problem with the new cohort, that this makes it a public health concern. Because as soon as he has hepatitis C and shares needles, Mark's going to get it too. And so is Julie and Bill. And we have no concerted effort to screen these individuals for hepatitis C. They're not even engaged in the healthcare system. This is a paper that came out in Gastroenterology last year. And it's very concerning. Because it shows here in the first column that in a dozen states, the rate of hepatitis C in younger adults exceeds that of baby boomers. In 4 states, it's similar. And the right column, where the young adult rate of hepatitis C, it's approaching that of baby boomers. So we're in the midst of another epidemic of hepatitis C. Another epidemic. And we need to do a better job. So this is a nice slide from the CDC, highlighting how now we're seeing a new flare of acute hepatitis C coming to our practices. And unfortunately, this is a reflection of the opiate epidemic, of drug use. And if you look at these states that are highlighted with opioid use, admissions, they parallel the growing hepatitis C epidemic in young adults. This is also a very sad slide. For 20 years, for over 2 decades, the most common source of organ transplant in this country was a motor vehicle accident. The most common source of a liver transplant or kidney transplant, lung transplant, heart transplant. Today, it's a drug overdose. The most common source of an organ transplant today is a drug overdose. No longer a car accident. And this is young people who are not even in the prime of their lives. So in terms of eliminating hepatitis C, think about it. Can you cure hepatitis B? You heard from a great lecture from Dr. Hahn that curing is still 5 years away. Best case scenario. I've been hearing 5 years for 5 years. Can you cure diabetes? Can you cure hypertension? You can't even cure hair loss. I'm taking my biotin every day like a religious, ain't doing anything. And my spot's getting bigger and bigger. Here's a condition that could kill you. They cause cirrhosis, liver cancer, liver failure, and yet you cure with pills that are not effective but safe and tolerable. Dr. Hepsno, I went to his office a couple of years ago talking about a drug called talapivir. Right, Dr. Hepsno, remember that? He gave me a hard time for that. And we were excited. I mean, we went from a cure rate from 45% to 75% overnight. But adding a pill to interferon ribavirin. One pill. And then we started using it. Oh my God, the people couldn't take it. My first 5 people, I had admit 3 for a blood transfusion. And they got the hand, foot, skin reaction, and people had cirrhosis decompensated. So now we have drugs that are effective and safe and tolerable. We can cure hepatitis C. And part of the reason why is hepatitis C does not go into the nucleus like hepatitis B does. It stays in the cytoplasm, remains a target for viral eradication. So when we talk about starting hepatitis C therapy, we got to take a number of steps, confirm the infection with the viral load, checking someone's genotype. And you could challenge me. Sammy, why take a genotype? Why do it? And you're right. The WHO says there's no need for it. We have pangenomic drugs. Unfortunately, we're dictated by insurance companies. They still wanted to get a genotype. We have determined the severity of fibrosis. Very, very important. And we have great tools like FibroScan. We have blood tests. And we have to assess for hepatitis B and HIV, because if you have 2 viruses, B and C, one is active, one is dormant. Usually B is dormant, C is active. And when you treat C, the B could flare. Similar to what Dr. Heinrich talked about with chemotherapy. And if you have cirrhosis, you got to screen for liver cancer. For how long? Forever. Forever. We talk about screening for varices, and also if they have recent infection, one about reinfection. Because one of the things we want to talk about today is treating hepatitis C is easy. Treating the disease, different conversation. So we have ways to address fibrosis. Probably the growest, fastest, best modality we have is a FibroScan machine, readily available. You can use it for other disease tests as well. We've gone away from doing liver biopsies, invasive, slamping air. We have commercial blood tests like FibroSpec, FibroSure. We can also use MR elastography as well. So we have a number of tools to assess for the amount of liver damage, and this is critical when starting hepatitis C therapy. You got to do it before starting therapy. These tests have not been really well validated post-cure. So we don't really know how to interpret these tests post-cure. We do not. You got to get a baseline before curing hepatitis C. All right, cure rate. It's incredible. The cure rate is over 95% of the time. I mean, can you cure anything else 95% of the time? Can you cure pneumonia 95% of the time? Can you cure UTI or ear infection? No. 95% cure rate. And we have a lot of options. And your primary choice depends, on whether they've been treated before or not. Are they have cirrhosis? If they have cirrhosis, are they compensated? Or are the eyes yellow? Are the eyes so yellow that they're fluorescent? Do they have ascites? Are they driving by braille from encephalopathy? Do they have kidney failure? Are they on dialysis? And a lot of times it comes down to insurance. And that's okay because they all work equally well. Look, it gets boring. Overall cure is 98% with this regimen. 98%. So Dr. Han and I go to meetings where we argue about, why did 2% fail? We become so greedy. Across all genotypes, the cure rate, it's consistent. And there's another drug combination, also 98, 99%. And with cirrhosis, equally high. Equally high. And if people don't respond to therapy in those rare 1 or 2%, we have other options. Also safe and effective. So hepatitis C therapy, our surrogate marker efficacy has been a viral load. Now we have data that translates to improve survival, decrease fibrosis. Here's a study by Robert Wong, a good friend of ours from Alameda Healthcare, big name in healthcare outcomes, patient-related outcomes, and shows that people after a cure, they have decreased fibrosis. But look at this. This is fascinating. The fibrosis improvement continues to occur after you're cured. The fibrosis gets better over time because the culprit, the virus, is no longer there. So you get fibrosis regression over time. And it continues. It continues, even at 4 years. And we have similar data for liver failure. We have similar data for liver failure that the Child-Pugh score, the MEL score, gets better over time. This is an older study from 6 years ago, 7 years ago, showing that people survive, overall survival gets better. And then we have also data that shows liver cancer rates go down with cure with DAs. This was originally very controversial. Today, it's taken as gospel. And this is from the VA database, Linda Bacchus, who's published a lot with the VA database. And what she highlights, and this is one of the very few studies that exist, that shows even people when they have mild fibrosis, even people who are no cirrhosis, no bridging fibrosis, mild fibrosis, they benefit. They live longer. And we think one of the reasons why is because of eliminating or reducing the risk of extrahepatic manifestations. So this is a very important slide. It shows what the impact of these drugs have on our society. If you look at the liver transplant list in Europe, in the United States, it's changed. You know, right, Steve? 10 years, where's Steve Hahn? No texting, Steve, right? All right, no texting. All right, 10 years ago, someone came to for a transplant committee. The most common reason will be hepatitis C, liver failure. You know, yellow eyes, liver failure, MEL score was sky high. 10 years ago. Today, the most common reason for transplant is alcohol. 10 years ago, they had hepatitis C, they're rare, and cirrhosis, and you had transfer cirrhosis, liver failure. They rarely had liver cancer. Today, if someone comes to a committee with hepatitis C and cirrhosis and hepatitis being cured, they don't have liver failure. They've got liver cancer. Over 50% of people today that go to transplant hepatitis C go for transplant not for liver failure, go for transplant for liver cancer. Because people's MEL scores have improved and the Child-Pugh scores have got better. And they're living long enough to get liver cancer. I remember Dr. Draws and I were talking about a year ago about people with hepatitis and HIV. And there's a paper 20 years ago that argued that people with HIV never got liver cancer. They never got it. Why they didn't get it? They all died. They didn't live long enough. We have the opposite problem. People living long enough from hepatitis C, and they're getting liver cancer. They're getting liver cancer. So this is a nice flow sheet by Mark Sawatsky, John Hopkins. And he reminds us that treating hepatitis C is a continuum of care. He reminds us that someone's got cirrhosis. They got to be screened for liver cancer for the rest of their life. You don't stop putting the disease. And I'm sure you have people in your own practice, and you heard about from your colleagues, have that people with liver cirrhosis, they got cured, and they still get liver cancer down the road. You got to do ultrasounds every 6 months. We had a patient from one of my colleagues, a good friend of mine, and who had liver cancer. And he's referred for treatment for liver cancer. I see that patient, and I saw a patient in November, the AAP was 4,000, in January it was 12, and he died. And the family asked, Dr. Saab, my dad has cirrhosis. Shouldn't he have been screened for liver cancer before here? If you have your cirrhosis, even if they're cured, you got to screen for liver cancer. That's why assessing the fibrosis is so critical. And the other part of the continuum, how much time do I have? Oh, I'm over. Okay. Gina says speak faster. No, Gina. I have a seizure. So in patients, okay, the other part of the arm is that people who are newly infected, new cohort, the new hepatitis C face, worry about reinfection. They could get reinfected again. could get reinfected again. This is a plug for a paper published in Hepatology, and we're going to skip this in the interest of time. This is WHO. WHO says in our lifetime we can eliminate hepatitis C. You know, if we could rev up our diagnosis rate, you know, having and rev up who gets treated and maintain our curative rate, we can eliminate hepatitis C in the next couple decades. And this is the algorithm that WHO has. And one thing to emphasize is you do need to assess fibrosis scores for liver cancer. They're not very hard on genotype, but you do need to assess fibrosis scores. So hepatitis C, as you guys know, is diagnosed through blood tests. The goal, unlike hepatitis B, unlike HIV, where you have suppression, the goal is cure. But remember that you're treating an infection and a disease. And hepatitis C in our lifetime could become a rare disease. Thank you for attention, everybody. And I'll step down here.